Okay, thank you, Dr. Matsumoto.
Thank you very much.
Your lecture was very wonderful.
Thank you very much.
Okay, so let's move on to the next speaker. I'd like to introduce Dr. Do-Hyun Park. I think everyone know him. He is one of the most famous endoscopists in Korea. He published so many papers. Okay, his title is ES treatment with flap stents. Professor Park,
Yeah.
can you hear me?
Yeah.
Long time no see.
Yeah. How are you?
Hi, I'm fine. Okay, so please start.
Thank you. Thank you for your nice introduction. So today I talk about expanding indication of anchoring flap stents for EUS-guided transhepatic biliary drainage, ETBD. Disclosure is as follows. And today I topic focus on ETBD because this one is including EUS-guided hepaticogastrostomy and hepaticojejunostomy and hepaticoduodenostomy. So in terms of transmural stenting, transmural stenting can be metal or plastic, and transanastomotic and transmural stenting can be performed by the plastic stent or plastic and fluid curve stent. Update in 2021, benign disease of biliary obstruction, fluid curve metal stent with anchoring flaps 6 mm hepatogastro with 10 cm lengths and hepaticoduodenostomy with 8 cm lengths. In my fashion, and in terms of a migrant obstruction and so partially curved metal stent with these flaps, HGS 8 mm in diameter and 10 cm in length. Listening is increased number of pediatric patients have requiring for the ETBD, and demand of patient for internal drainage, especially from long-term PTBD. Now is move on the from the hurricane balloon to the 4 mm ram balloon or cystotome for fistula dilation. Let me show you some video. This patient has a pancreatic cancer with duodenal obstruction, and patient has a PTBD almost 6 months for long-term PTBD, and patient requests for the removal of the PTBD tube. So I performed the PTBD assisted EUS-guided hepaticogastrostomy. As you can see, this is first step is injection of the contrast through the PTBD tube. Even though there is decompression of bile duct, is very easy for the EUS-guided hepaticogastro with the PTBD assist EUS-guided hepaticogastrostomy. This one is a guide wire or O2-5 glide, and for this patient I performed the partially curved stent without fistula dilation. This is their stent. Here is a metal tip and tapered in the 3-French catheter inside of stent. And basically, sometimes pushability is very good for the hepaticogastrostomy with one-step stent deployment, even though B3 or B2. This patient is a little bit, there is some difficult for the puncture. At the time, we need some muscle. And then successfully, we had the without dilation is one-step stent deployment of the HS stent. And there is some problem is the deployment of inside the metal stent. Sometimes at the time we have the to and fro, and slightly the stent is deployed inside the metal stent. Then the stent may be going through there is proximal bile duct sometimes. Here, as you can see, there is a proximal dilation. Here is duct is uncovered metal stent. This is a partially covered metal stent here. Here is uncovered, and the remaining is fully covered metal stents. So I think maybe hepatico-gastro for such kind of a very stable scope position. and there is a pushability is very important for the successful EUS-guided HGS. For this patient is I mentioned the PTB the assist EUS-HGS when you have contrast injections through the PTBD tube. There's a micro bubble inside the bile duct. We can perform the puncture of site. Here is some bubble here after contrast injection, and we can choose the PTBD assist HGS for best access point here. It's a very comfortable procedure because even though failed of EUS-HGS, but this patient already have the PTBD tube. So yes, finally is perform the stent here. Next case is a patient is a 63-year-old female patient has gallbladder cancer with bile obstruction and pleural stent malfunction. Patient has unilateral uncovered metastasis before, and patient has disease progression, gallbladder cancer, and the separation of bile duct and left and right posterior anterior duct. What kind of choose of such kind of patient for you? I think my design for this patient is EUS-HGS for left side and remaining at the dilated bile duct in the right anterior posterior is performed the transpapillary meta stent for this patient. So for this patient, previously I performed the EMBD, EUS-guided we have drain of tube. Then we performed EMBD assist EUS-HGS for left EUS-guided hepatic gastro. So for this patient, as you can see, we performed EUS-guided HGS with EMBD assisted. So when we injection of contrast or saline inside the bile duct, we can choose the bile duct where is the micro bubble. Here is a little bit have as a micro bubble, and there is some echogenic, some debris or something here. We can choose the best access points for EUS-guided HGS using EMBD tube. Here is puncture of the B3 position. Then finally perform the HGS stent here. Next patient has a 69-year-old female. Patient has B3 cholangitis, despite right PTBD and B2 advance of PTBD tube before. In a patient with hepatic jejunal stricture and recurrent cholangiocarcinoma. Already patient has right PTBD. This is through the left PTBD B2 position, but patient has a septic condition. As I performed EUS-guided HGS for this patient. When I puncture over the B3 and the O2-5 guide wire, then I used to perform this patient with a partially covered stent. Here is there is some focal and segmental stricture of the B3 position. Here is a one-step device for HGS with this is partially covered with the distal flaps here. It's very easy for HGS with even though very angular position. So let me show the some EUS finding. This patient has a very marked dilatation of the bile duct, and there is a large amount of the sludge or some debris inside of the B3 duct. And after puncture with the needle and guide wire goes through the hilum, and here is we have used the one-step device with partially covered with distal flaps here. Finally, we have some inside walking channel. It's a release technique, intrachannel release technique. There is pus is drained after procedure here. Finally, we performed the PTBD assisted and anastomotic stenting in the right and left and hilum. Next patient is a very difficult case. I think this is my most difficult case ever. 36-year-old female had patient had recurrent cholangitis following Kasai operation. Because patient has multiple intrahepatic duct stone and ETBD is failed for the intervention radiology. We have performed EUS-guided hepatic gastro here, punctured, and then performed the left side EUS-guided hepatic gastro. But the right side of the stone and the cholangitis is still there. Here, patient has suffered from the recurrent cholangitis. Intervention radiology is difficult and impossible for the right PTBD here because patient has atrophy of the right liver. And we tried through the HGS for right side approach, but it's very difficult and fail. Let me show the EUS-guided hepatic duodenostomy with the knock the stone technique. Because as you can see, it's very far away from the duodenum and the right liver. As you can see, there's just the inject of the portal vein. So it's very difficult. But there's no choice because we failed over the deep enteroscope, and there's still just a vessel and after puncture. So, but on EUS, there's a scope. Stone is inside of the bile duct. So we have performed here is needle puncture of the stone here. As you can see, here there is a stone here. I just perform of the needles for the knock the stone means needle is the progress of the stone. First, I use the 22 gauge needle first, then it is 1/8 guide wire. Then we have a change with this one with a RAM balloon as a final successful EUS-guided hepatic duodenostomy. Either inside of the stone is hepatic duodenostomy performed with 6 millimeter fully curved dual flaps metal stents. For hepatic duodenostomy, I think there's ACM length and 6 millimeter in diameter is always successful. So after RAM-bound dilation and is stent release and remainder distal portion is intrachannel release technique is hepatic duodenostomy was performed without any problem. So let me show the EUS finding. As you can see, there is a stone here, but it's very far away from needle, and we are just needle, just a touch of the stone. Then here is a stone. We can use the 22 gauge needle and so very thin guide wire. Then we change of the guide wire through there is a lamp balloon. Here's a knock the stone technique. It's finally so we can perform the EUS-guided hepatic duodenostomy with dual flaps metal stent. Some patient, as you can see, this patient is a 60-year-old female. Patient has recurrent cholangitis after excision of choledochal cyst and one eye anastomosis. And sometimes there is intrahepatic stone is blocked of the left main duct, and guide wire is could not go through the hairs. Then even though we have a dilation of the fistula tract here, left side, it's a metal stent is very difficult. It's impossible for the right angulation. Here, so at the time we are the change of the guide wire as like there is through the towards the peripheral duct. Then in the stent is deployed as like this one. It's more easier than of the central or towards the hollow. But some risk of the some bioleak at the time I used the nasal biliary drain tube inside of the stent is very useful for the prevention of the cholangitis or bioleak as like this one. This is my more youngest patient for EUS-guided hepatic duodenostomy. Patient has a 10-year female, and the patient has recurrent fever and because of the isolate right posterior duct dilatation with peribiliary inflammatory myofibroblastic tumor. Patient has recent laparoscopic exploration. Patient mass is a common hepatic duct enhancing mass, and 2.3 cm is, but it's only excisional biopsy was available. Liver enzyme is high. As you can see, there's mass is separated left and right posterior duct here. And as you can see, previous ERCP is just performed left and right anterior, and posterior duct is failed, and patient has still has cholangitis. What's your opinion for this patient? So some doctor maybe recommend the PTBD, but patient is only 10 years, so female. So I recommend the hepatic duodenectomy under general anesthesia. Is a biopsy is compatible with the myofibroblastic tumor. I performed the hepatic duodenectomy as like this one. There is a separation of the and complete obstruction of the right posterior main duct. We performed the guide wire and lamp balloon dilation, and finally in 6 mm diameter and SCM is length is of flicker metastem inside there. After procedure, we have performed the left and right duct is performed the ELBD plastic stent. Let me show some video here. For this patient, we performed this procedure under general anesthesia, and it's a very comfortable procedure. But patient very small patient, as the scope is very sometimes difficult for the maneuver. As you can see here, is a performed of the puncture. But sometimes is extravagation because we are first trial under the central duct, because we are performed this one is a more central area, but it's very difficult because there is a mass here, and it's very difficult to control of the central approach. And we have performed the peripheral duct approach again here, as after dilation of the ram balloon here. So flicker of the metal stent with anchoring flap here is finally successful procedure, and we change of scope in ERCP and transpapillary stenting in left and right anterior duct here. But a little bit there is patient has a retroneal peritoneum, but patient has tolerable, and there is no further or serious adverse event. This one is a video, is ES finding. So we performed the hepatic duodenectomy is as usual duodenal bulb here. Is a approach of the peripheral duct. Firstly, we are approach the central is more easier, but there is my concern is some collateral vessel here. There is a bleeding maybe or extravasation of sometimes may be possible. So finally, we have the hepatic gastrostomy with follicular metastasins is like this one here. And this is follow simple X-ray. And patient has performed, and after 2 months, we have a follow-up ERCP with plastic revision. And after removal of the follicular metastasins, there is a track, is a neopapilla is here. And we are through the, here is right posterior to the B6 to the B7. Here is plus stent, and we change over the both left and right hepatic duct. And the patient has no fever, and now it's stable. We are scheduled the ERB change. This one is performed on the yesterday. The patient has multiple session of the PTBD before, because patient has a cystic excision and choledochal jejunostomy before, and recurrent intrahepatic duct stone, and patient has suffered from the multiple PTBD stone removal, and patient has fear of the some revision or re-attempt of the PTBD, and patient has recurrence of the right posterior duct, right intrahepatic duct, and cholangiohepatitis. We have performed the duodenal bulb, and we bioduct in the choledochal is a duodenostomy, as like this one, and performed in the anchoring flap stent. but there's concern of the leak or some stent migraines before. I think is I performed the EMB is also performed. And here, and the follow-up in the CT scan is the flap is anchor of the inside of the bile duct, and the stent was stable. The concept of fully curved metastent with the dual flaps, the migration is free of adverse event following intervention EUS. No migration and removability is stent deployment, and durable stent pattern is more important. 60 mm fully curved metastent with anchoring flaps with a French stent introducer is maybe useful. And for HGS, for dual flaps, 60 mm in diameter, 10 cm is okay. And hepatic duodenal is 8 cm in length is okay. This is my before data. 60 mm has 3 flap, and there's a unique one is flap has a curved membrane, and then is less traumatic in the bile duct and easy removal. This is a 10 or 8 has 4 flaps. For the metastent deployment, the most important is 1/2 of metastent deployed first on the EUS and fluoroscope guidance. Remaining was performed with the intra-channel release technique. But problem is a partially curved metastent. Sometimes here is the tumor engrossing in the uncurved portion. At the time, we used the through the mesh technique. At the time, we had performed the fully curved anchoring step inside of the partially curved and tissue hyperplasia and uncovered metastent is very useful. I mentioned the conversion of external PTV to EUS-HGS is very useful for the beginner for learning about HGS. For EUS-guided hepatic duodenostomy, I recommend during procedure, U-shape scope, long scope positioning duodenal ball in the fluoroscope guide is very useful. And for ram balloon, hurricane balloon is okay, but I recommend the 4mm ram balloon, and fully covered metastent with anti-migrant property is very important. Recently I have a long-term data for hepatic duodenostomy for various patients. So I think maybe most important is right anterior, maybe inferior than right posterior duct for in terms of stent patency. I recommend the right posterior duct for hepatic duodenostomy, I think. Is my summary. Increased number of patients may be required for ETBD following bile duct resection and one eye anastomosis. ETBD can be safely performed by expert hands. Anchoring flap with curved membrane bile duct may prevent this migration. Recurrent metastent for benign biliary obstruction with the possible revision may be okay. And partially curved may have a tissue hyperplasia, or fully curved has a focal cholangitis and it 8 or 10 mm diameter. I think 6 mm of fully covered metastent is okay for malignant biliary obstruction. Thank you for your kind attention.
Thank you very much, Professor Park, for your very informative talk and nice, very beautiful videos. Okay, so any questions from panelists? Okay, Shiomi, please.
Oh, long time no see. Do you remember me? Okay.
Yeah, sure.
Okay.
How are you?
Okay. Oh, fine. And thank you for the great presentation and your great technique. I have one question. And PTBD assist EUS-HGS is a good option for doing HGS safely. But this procedure is sometimes challenging. And because bile duct wall is a thickness and hardness due to recurrent cholangitis. And when dilator is difficult, could you tell us your tips?
So it depends on the how much patient has have a PTBD before, because a patient once 6 months of, as you mentioned, there is some fibrotic and no dilation so much. But if patient has a very severe obstruction in the distal CVD, at that time we are inject our contractor, but patient may have sometimes severe pain. At that time, there is a micro bubble or some possible. You can check the puncture with the peripheral duct. Another option is use with the 22 gauge needle.
No, 20. Okay.
Yeah, it's more easier for the puncture, but
Okay.
there's a problem of the guide wire. But I
Yes.
think maybe is another tip is clamping of the PTBD tube before procedure about the 3 hours or something. Then there is a little bit more at the dilate sometimes patient.
Okay, and do you use the cautery dilator or another dilator?
As usual, I perform the cautery dilator using a cystotome or so-handle stent retriever.
Okay, thank you.
Okay, Ogura.
Thank you for your.
Ogura and the Do-Hyun are the two tops in the world about the EUS-HGS.
No.
Okay.
Okay, hi, thank you for your good lecture. So my question is hepatic duodenostomy. So compared with EUS-guided hepatic gastrostomy, stent migration may not be occur in HDS. So please, could you tell us clinical benefit of fully covered metal stent during EUS-HGS?
So I have never experienced of the distal migration of the EUS-guided hepatic duodenostomy.
Yes, so I use usually plastic stent in HDS. Why do you use fully covered metal stents in hepatic duodenostomy?
Yeah, because I use the 6mm fully covered metal stent, and so first one is some patient is this is very useful for the stent revision because it duodenal ball, the plus stent is very small, so diameter, even though it's the removal of the plus stent after 2 months something, very sometimes difficult to find out with the fistula opening sometimes. But 6mm diameter of the fully covered metal after removal, this is very patent of the for stent revision or something. I recommend over the metal stent.
Okay, thank you. Okay, thank you.
Okay, we have so many discussion, but time is limited, so let's close this session.